All right. Good morning, everyone. Thanks for being here on Friday. How's the figure? Did you break it? You did it? Oh, sorry. Do you know which phalanx it was?
Yeah, it's the very tip. I gotta talk to doctor, so it like popped down.
Oh, painful. Oh, do you have any x-rays of it?
Yeah, I do.
Oh yeah. We're actually gonna if you're I mean this obviously up to you, but if you're willing to share, it would actually be a great example to show in class. I can do it. You can send it to me and I can put it in the next lecture. So we'll get to the hands of the bones of the hands coming up. I'm sorry though, that's not fun.
But honestly, it's not that bad.
Yeah. It's weird timing that you broke it just as we were talking about
I
those
know. I
bones.
was
Yeah.
making jokes with my friends. I was like, apparently I just got too excited for lecture on Friday.
Yeah. So just be more mindful when we get to like the heart unit and stuff like that. Like we don't want anything. Ouch. Okay. Well, I'm glad you're back in action anyway. Yeah. You're on a team too, right?
I just managed too much.
Each minute. Okay, so you're just not gonna. Okay, you're good. Okay, good. All right. Well, good morning, everyone. Broken fingers aside. Glad you look at. I even have an X-ray of the bones of the hands today. We're gonna continue with the appendicular skeleton today. Probably working through most of it. We'll probably wrap this up on Monday. So our agenda looks like this. I got a quick review of your ticket out from Wednesday. The bones connecting the sternum to your carpals. Then we'll talk about the upper limb. We'll continue. We left off on the ulna and radius. We'll get into the pelvic girdle. I have a drawing activity or a review activity that's not drawing today. And then we'll get to the lower limb and we'll just continue that. Like I said, whatever we don't get to today, we'll wrap up on Monday. And then I want to offer some reminders. We have a ticket out and of course it's Friday. So you get a Venn diagram, which today's is, you'll see. Just by way of quick review, I asked you on Wednesday to name for me the bones that connect your axial skeleton to your all the way down. Let me rephrase that. I asked you to name the bones that connect the axial skeleton through the shoulder girdle or pectoral girdle down through the bones of the upper limb. And so what I was looking for was this series of bones. So starting with your clavicle, remember your clavicle articulates at the with the manubrium of the sternum. So that's the superior most part of your sternum at the only joint that connects your upper limbs to the axial skeleton. We then have the scapula. So remember the clavicle articulates laterally with the acromioclavicular joint there of the scapula. And then your scapula, of course, articulates with your humerus at your shoulder joint here. Remember, we have the glenoid cavity is that kind of shallow cup-like structure on the scapula where the head of the humerus articulates and our very, very flexible, but a little bit unstable shoulder joint. The humerus then articulates with the ulna, a little bit with the radius here, but most directly with the ulna at the elbow. And then your radius, of course, articulates with your ulna proximally at these proximal radioulnar joint. Remember, that is the joint that is this kind of cylinder so that the ulna can rotate in relation to the ulna. Then we have those joints, those bones articulate with the carpals, and most explicitly the radius is articulating with these carpals directly. We'll talk about that today, and then we can go and talk about your phalanges after that. So the series of bones basically from your exoskeleton from your fingertips looks like this. You should know these bones in the order in which they connect and also the names of these major joints and structures on them. So just a little bit of review. I noticed the class didn't do so well on that question. I don't know if the question was unclear or we just weren't kind of thinking in these terms, but I want to make sure that we had this information. And here's a little bit of a giveaway. I'm going to ask you this exact same question on your ticket out today, just to kind of recheck your understanding and make sure that after reviewing it, this is kind of all making sense for you. What's noteworthy here is that these bones are in sequence. I know the scapula is a little bit irregular shape, but notice that we go down the sequence from clavicle to scapula to humerus, and then the ulna and radius. We kind of have these pair joints in the antebrachium, but they're in sequence. In other words, the clavicle never articulates with the humerus, and the scapula never articulates with the axial skeleton. So I want you to think of these bones kind of in this sequence. Questions you have about that? Yeah, please go ahead. Say that one more time, sorry.
Um,
Which one? Mm-hmm. Oh, that's a good question. What would you say? I'm gonna put that question back on you. And what's your argument for that? Okay. Does anyone want to add to that or additional thoughts on that? A counter argument. Go ahead, Rich.
The ulna is more structural and the radius is more rotation.
Okay, and when you, what's defined, when you say structural, what are you referring to? Which structure?
The base is bone under forearm.
Mhm.
I don't know exactly that's the word.
Okay.
The radius revolves around the ulna.
Okay, okay, good. Let's hear more, Gia. Okay. Hmm. So you would say ulnar radius in that order. Okay, good. So there's no definite right or wrong answer. Both of these bones are the prominent bones of the antebrachium. Couple things to point out here, and your all of your points raise some really all of you raise some really interesting points about this. So structurally, we could argue that the ulna is a little more prominent proximally. It's a little bit thicker up here and gets thinner down here towards the wrist. Whereas the radius is a bit thinner proximally, but then gets wider and more prominent distally. So in terms of which is kind of the more important bone of the antebrachium, I would argue that they're probably about the same here structurally, right? Now this is going to be in contrast to the bones of the lower limb of the leg, in which we have a big old tibia and just a little thin fibula. So in that sense, the arm is going to be different from the leg in terms of the importance of those paired bones. Now, what I think, Marge, you said is that remember, the ulna articulates more with the humerus here. In fact, the radius doesn't actually directly articulate with the humerus at all. So it's really the humerus and the ulna that form your elbow joint. At the same time, it's the radius that articulates with your carpals directly. We don't have a direct articulation of the ulna in the carpals. So the radius is the bone that most is most prominent in the wrist here. So I would say that you would probably put these in order of humerus, ulna, radius, carpals. But the question just asks you to list the bones kind of going through. So either way would be technically correct. But if I had to think about what bones are important, what joints, I would say the humor or the ulna first because it directly articulates with the humerus, and then the radius because it directly articulates this rotating joint here between the ulna and radius. That makes sense? Am I? Cool, good points. Great. I appreciate that discussion. It's great to kind of work through those ideas. So with that in mind, let's get back to the appendicular skeleton and talk about, finish up. I've just got a little more to talk about the radius and ulna. Just as a quick review, remember this radio-ulnar joint here, the proximal radio-ulnar joint is this rotating joint where the radius essentially is rotating around the ulna, which doesn't move very much. Now, notice that here distally, we have the distal radio-ulnar joint. That joint is rather inflexible. The two bones are bound pretty tightly here, and so we don't see this rotation or anything like that distally. We see those two bones kind of moving together. And that's why when we're in the anatomical position, those bones are parallel, but when you flip your palms of your hands over, they cross as you see there. And so if we look at the ends of these two bones, so this is looking at the distal ends of the ulna and the wrist. So this is as if, let me make sure I got this right. We got the ulna and the radius, and that's going to be, yep. So that's going to be as if you're looking down at my hand right now, right? You can see that distally, we have this big surface on the radius, so it can articulate with the bones of the carpals. And specifically, we're going to talk about the carpals in a minute, but I want you to know the names of two of your carpals, and that is the lunate and the scapula. Those are the names of two carpal bones or wrist bones that articulate with your radius. You can see here we have the styloid processes on either side. Those kind of give extra stability to your joint as it moves laterally. We have a styloid process ulna and on the radius. So I like this view because you can see here how much more important in the wrist joint the radius is compared to the ulna. Now, those two styloid processes you probably know pretty well, and actually you can go ahead and feel them right now if you just gently, if you look at your wrist and kind of palpate right here, you can feel those two kind of bumps on either side. That is your radial styloid process on the side of your pinky and your ulnar styloid process on the side of your thumb. You can kind of see the shape that those bones make here. Now, because of the structure that those processes are important to control your flexion of your wrist laterally. So notice, be with you in 1 second, Marge. Notice that you can move your wrist rather flexibly kind of up and down, right? You've got a big range of motion there. Essentially, you can get to 90 degrees, up to 90 degrees. You have 180 degrees of motion. Moving your hand laterally, though, you're much more limited in how you can move it. You probably have about 30, 40 degrees laterally. And that's because these styloid processes give that extra kind of stability to the joint in that direction. Now, because of that structure, I'll be with you in 1 second too, Jada. These processes are very subject to breakage. You force your wrist too much in either direction. You can see in the radiograph here, they can fracture. And this is what often happens when you're catching yourself in a fall. Like your reflex when you're falling is to put your hands out, which is good because it's much better to injure your hands than your face. And this is a very common breakage in that scenario because it puts pressure on those processes as your wrist kind of bends with a lot of force of the fall. Marge, question? Sure, let me go back here. So I'm just going back. This is the distal end of your radius. And we have these two surfaces that articulate with the lunate. You can see that up here, and the scaphoid, which is the other carpal bone that articulates. And I'm gonna cover those. I'm gonna talk about carpal bones, and we'll show you the structure of those in a second. Right now, those bones don't appear in here. I'm just showing you the surface of the radius that articulates with them. Good. Thanks for that question. Let me get Jada and then Gia. Go ahead, Jada. Jada asks if carpal tunnel messes with those bones. It does not actually. It's not really an issue of the bones. And I have a slide coming up in a few slides that shows you what carpal tunnel looks like. I'm going to talk about that in a second. So hang on to that question. But it's an issue with the tissue surrounding the nerve, not the bones. Gia, go ahead. Yeah, sure. So this one looks like it is a fracture of the radius, and it looks like it's just kind of broken right along this process. Is kind of like cracked off. That is, yep, that's going to be the radius there. You can see the radius and it's articulating directly with these carpal bones here. You can see the ulna is kind of part of that joint, but it's not directly. Oh, this one, yeah, you can see this is the same hand from a different angle, and you can kind of it's admittedly hard to read, and I'm not good at reading X-rays myself. But if you look at it closely, and this image I believe is from your textbook, so you can take a look at it. But you can see there's like this gap here where you can see that part of the bone is just kind of cracked off. Good question. Thank you. Good. Cool. All right, keep talking about broken bones. This is fun. Okay, let's move on and talk about the bones of the hand, or in anatomical terms, the manus. I'll usually just call it the hand, but so those are synonymous, but I do want you to know that term, and your textbook uses it. And these are broken down into three groups of bones. We have the carpals, which are the bones of the wrist, the metacarpals, which are the bones of the palm, and the phalanges, which are the bones of the fingers. Now, kind of visualizing this in your palm explains why whenever we see like a skeleton, it always looks like it has really long, kind of creepy fingers. Because on our hand, we have these bones, the metacarpals are the bones in your palm right here. But when you're looking at a human hand, this isn't part of your fingers, right? This is covered up with flesh and muscle, and it's not that much muscle, but other connective tissue, and it's part of your palm. So your fingers, what we see as fingers are only your phalanges here. But if you removed everything but the bones, these metacarpals now look like these are just continuous fingers. And so that's why skeletons look like they have these long creepy fingers, because the metacarpals look like they're part of the fingers, when in fact, they're normally covered up with flesh, right? So let's talk about each of those groups of bones. Here is an anterior view of the right hand. So this is a right hand like this. And then here's a posterior view of the right hand. So it's the right hand like this below. I am not going to ask you to memorize all of the bones of the carpals. Happy birthday. I do want you to know the names of two, which are the scaphoid and the lunate. These are the two that directly articulate with the radius. And I do want you to know which side they're on. And so we have the right hand here. They're the two bones of two carpal bones that articulate with the radius. One way to remember this, and this is a mnemonic device that may or may not be helpful, but lunate starts with an L and it's on the ulna side. Ulna also has an on it, so you have the lunate on the ulna side, and then you have the scaphoid on the thumb side, basically. There's a good mnemonic device for that. So know the scaphoid and the lunate, and what is a little bit tricky is to be able to identify an illustration of these bones and know whether it's facing anterior or posterior. You can kind of tell by the shape of the carpals, but excuse me, what's important is if I told you this was a left or a right hand, you should be able to identify whether it's an anterior or posterior view simply based on the position of the arm. And of course, remember the radius. When we're talking about the wrist, the radius has this larger head. There's a whole bunch more carpals. We could get into them. Past iterations of the course I have, but there's a lot of information already, so I just want you to stay focused on a couple of those important bones. So going to the question often comes up is about carpal tunnel syndrome. Perfect. Thanks, Jada. This is an image. This is from is it from an MRI? I think it's an MRI. I'm not actually sure exactly what kind of image it is, but it's a cross section of the wrist. So looking down someone's wrist, you can see some of the large bones, large carpal bones, so the hamate, the capitate, the trapezoid, and the trapezium. And kind of surrounding these bones, there's what's called a carpal tunnel. And this is an area where a whole bunch of ligaments, as well, or excuse me, tendons, not ligaments, that was a mistake, tendons as well as nerves travel through your wrist. And what happens, your wrist is kind of a bottleneck because all of the muscles that control your fingers, and there's a lot of them because you can do a lot of stuff with your fingers, as well as the motion of your hand, all of those muscles are in your arm. They're not in your hand. And that means that all of the tendons attaching the muscles, those muscles in your arm to your fingers need to travel through this narrow area of your wrist. Now, your wrist also needs to have bony structures because it needs that support. And it also has to have nerves and blood vessels and things like that. So you get all of this stuff that needs to travel through a narrow space. And that space is called the carpal tunnel. And what happens is if it's known as a repetitive stress injury, when you do the same thing over and over and over again, and those tendons in that carpal tunnel get swollen, and they basically compress that median nerve, and they can cause numbness or pain on kind of throughout the hand, but mostly on the lateral side of the hand, so the thumb side of the hand. And you can see what that carpal tunnel looks like here. It's the nerve traveling through. There's all of these tendons around it. So if those tendons become inflamed, they compress that nerve and it causes trouble. So this is things like if you're working in a factory and you're doing the same thing all day, you can get carpal tunnel. I actually got a kind of very mild version of carpal tunnel from using a mouse all the time and sitting at a computer too much. And the way you hold your hand and the structure of your mouse can help with that for sure. But there's a whole bunch of ways that you can get carpal tunnel. And it's not fun. I don't know if anyone's had it. Like it just kind of sucks. Your hand just kind of hurts all the time and you don't feel like you can do stuff with it. So. Gia, I saw your hand up. Great question. No, it can clear up for sure. You can mitigate it. Sometimes, like if you get a really serious version, you can require surgery or something like that. For a mild version, basically changing the nature of the motion that you're doing and how often you're doing it can it can go away on its own. So for me, just as one example, I was holding my hand, I was resting my palm on a table and using a mouse like all the time. It's actually when I was in grad school and I was spending a ton of time at my computer. And you're actually a better way to hold the mouse is to keep your elbow and your wrist elevated and to hold it like this. But what I ended up doing is actually teaching myself to use a mouse with the left hand. So I could use the mouse it took like 3 days, but then I was pretty good at it. But then I could just use the mouse with my left hand and it wouldn't always be in right hand. When my left hand gets tired, I could just switch over. So it was just a matter of reducing the amount of time I was using that. Good. Jada, does that answer your question from before? Cool. So you can see here, just to go back to your question, you asked about the bones. The issue here isn't the bones, but it's important to note that it's the bones because you have all of this stuff in this narrow area. The bones are what kind of keep that carpal tunnel in a tight space. And thus, when the tendons become inflamed, the nerve gets compressed. Cool. All right, let's talk about metacarpal, the metacarpus and the metacarpals. You have 5 of them, which is not surprising. These are actually really easy to know. They're simply numbered 1 through 5 with Roman numerals. The only tricky thing to remember is that your thumb is number 1. So you've got metacarpal 1, which is like down here, 2, 3, 4, and 5. Proximally, they all articulate with your carpals, right? Distally, they all articulate with your phalanges, which we'll talk about in a second. And that's really all I'm going to say about the carpals, the bones of the palm of your hand. But no 1 through 4. I might show you a diagram of a whole hand and point to one of these and say, what bone is this? You would say metacarpal 3, right? I will not give you just like a random metacarpal out of any context whatsoever and say, which metacarpal is this? Because I don't know if I could tell them apart. I could probably tell one from the other, maybe 5, but in terms of telling 2, 3, or 4 apart, they're all, without any context, you need more information to really know that. There's some subtle differences in the shape of the proximal end here where they articulate the carpals, but we're not going to get into that level of detail. All right, just as the metacarpals are named 1 through 5 based on their position, so are the phalanges. So let me just actually give a little grammar here. Phalanx is the singular and phalanges is the plural. It's kind of a weird Greek-rooted word. Phalanx actually comes from when all the soldiers would like line up and go into battle with their shields in front of them and all their big spears pointed out and move kind of in a line. And then they decided to name the finger bones after that because they're kind of all in a row pointing the same way. So phalanx is a single bone, phalanges is plural. These guys, as I said, are also named numbered 1 through 5. So this is an anterior view of the right hand. So this is my hand like this. And you can see we have the thumb here and then the rest of the fingers. The thumb is known as the pollex. This came up when we were talking about regions earlier in the semester, but just know generally I'll refer to it as the thumb because that's very clear and specific, but you should know the term pollex as well. Now, phalanx number 1, or your first digit is a better way to say that, your thumb or pollex is different from the others in that it only has 2 phalanges. I'll be with you in a second. The other 4 fingers have 3 phalanges each, and they're very cleverly named your proximal, middle, and distal phalanx. So Holly, you injured the distal phalanx of your 3rd digit, your 3rd distal phalanx, which is this little guy right there. Just as a little aside, humans and most other mammals actually have the same arrangement. We have 2 phalanges on the first digit and then 3 on each of the subsequent digits. Gia and then Jada, go ahead.
looks like.
Yeah, that's a great question. Actually, we're gonna get into this in lab the following week, but there's a kind of joint here called the synovial joint, because it's very flexible and filled with this fluid called synovial fluid. That you find between each of these, and that's what allows your fingers to bend as they do. And so there's a capsule around here, there's ligaments attaching these bones, there's fluid and cartilage in between. We're gonna learn about the structure of those bones. So they're directly articulating, and that's why your fingers can do all the great things. But what's interesting is that you're also limited. Your fingers bend very well this way, right? But you can't bend them at all in the opposite direction. That's because of the structure of the structure of those bones at that articulation. One last thing on this slide, there are two little bones in your thumb here called sesamoid bones. We're going to come back to this idea later in class, but I want to make sure you've got this. So sesamoid bones are bones that develop within ligaments. And I'm going to put a definition. I don't have this on the slide. Sesamoid bone. I'm going to call it a not free floating. What's the word I want to use? I'm going to actually be more specific. I'm going to call it an unarticulated bone that develops and is embedded in ligaments. So we have a series of a handful of these in our body, and they're these tiny little bones that are basically embedded within the ligaments of the thumb, and they provide a little bit of extra kind of mechanical leverage for when you bend your thumb, and especially your thumb is the strongest of your digits and has the capacity to basically produce extra force. And the sesamoid bones in this ligament kind of facilitate that without getting too much into the mechanics. We have other examples in your body. Now, we haven't talked about this yet, but can anyone, just thinking about what you know, guess at another sesamoid bone? Patella, yep. So this big old bone, your kneecap, right? That is the largest and most important example of a sesamoid bone in the body. So that bone is kind of embedded in these ligaments that run from your upper leg to your lower leg, and it serves as important functions in your knee that we'll talk about a little later. But basically, it allows you to have extra leverage when you bend your knee, and also protects that sensitive joint. It serves as a little, I like to call it the knee helmet. Good, excellent. So those are sesamoid bones. Questions on that? Jada.
Would it be at the top of like the bottom of the proximal and right?
Yeah, so this is an anterior view of the right hand. So this is like this, right? Anterior right. Yep, that's right. And so basically your knuckles are the joints. Your knuckle is just what we call a finger joint, basically. Yeah, and that's what, like, when you crack these, what it does is it changes the pressure in the joint capsule, and then bubbles form with a little fluid that's in there. It's kind of cool. And then it takes a while for those bubbles to reform, which is why you can't crack your knuckles like over and over again. Exactly. Yep, Chief. Like right here? Yeah, they do. That's where your skin is folded because you're constantly bending there. So, so you can see, like, that's basically right where that joint is. And if you grab your finger and kind of bend it, you can feel how those two bones are articulating with each other and feel where one comes up and the other one goes down. Good, Marge. Yep.
Do you know, like, when moms because they'll get big? Is that
Right. It is not. It is, yeah. The only, so I've actually looked at this because I was very curious, because I knuckle cracker and other joint crackers sometimes too. But it doesn't have any long-term consequences. I'll actually show you a short video on this. So I have this for this class. I'll have to dig it up. But a video on knuckle cracking. And there was this guy who cracked his knuckles of one hand for like 30 years or something. He always cracked one hand and not the other to see what would happen. Granted, it's a very small sample size, but there was no difference. I'm just gonna write in my notes to myself to get that. It's like a 5-minute like TED video. And I'll show it in class on Monday. Because it's interesting. And there's so many like myths about knuckle cracking. The only thing it can do is basically when you're cracking your joints, you're kind of forcing the joint to go beyond its normal capacity. And if you do that a lot with joints, whether you're cracking them or not, you can just stretch those ligaments and cause the joint to become a little bit less stable over time. But in general, it doesn't really hurt anything. God, I'm glad you asked that question. That always comes up. We'll get that video for you. All right, I'm gonna skip the pelvic girdle for the moment and go ahead to a little bit of review here to mix things up. We'll get to the pelvic girdle in a second. Where are we? Okay, so here is a diagram for you. You'll have this in your notes. Go ahead and scan it. And I just want you to label the features of the humerus that you see. So in other words, this will pull up a diagram with some blanks on it. Go ahead and take a minute and fill in those blanks. You can either recreate the diagram in your notes, or if you have a laptop and want to pull it up, however it works for you to do this. You could just make a list of it is fine. Actually, drawing the humerus probably will serve you well to just draw a quick sketch of it. But whatever works best for you is fine. Just a quick review. All right, how are we doing? Give me a quick survey. Just point up the number of fingers to the number of minutes that you need. If you need another minute, give me a 1. If you're good, give me a fist, 2 or 2. Okay, let's take another couple minutes. So I want to make sure you got this, and then we'll review it together. All right, let's bring it back and you can continue with your diagram as we review it. You should have something that looks like this. So this is a posterior view. So real quick, is this a right or a left humerus? If it's the posterior view. Correct. Yep. And how did you know that? Yeah, so that part's going to be, the big head is going to always point medially. So this is as if I'm standing like this in the anatomical position. See the trochlea really clearly here. The head of the humerus is pointing medially towards my glenonic cavity of my scapula. Good. So there's the major features I want you to know. The head of the humerus I just talked about, the greater tubercle, the radial groove, the deltoid tuberosity. So the radial groove is kind of like a shallow, I don't want to say pit, but it's an indentation in the bone, whereas a tuberosity is a part that sticks out. Then we have the olecranon fossa. This is the kind of this flat area on the back of your humerus. And this is the area where your ulna has that C-shaped structure, the olecranon, and it folds up into there when you extend your elbow. Hence the name olecranon fossa. And we have the medial and lateral epicondyles. So this is the attachment point for some important muscles, in this case associated with the wrist and digit flexors. So I mentioned that the tendons of the muscles that move your fingers and wrist travel through your wrist. They also actually travel through your elbow as well. Those muscles actually attach on your humerus and then end up articulating bones that are that far away, which is kind of cool. Not articulating, excuse me, flexing. That's the. So that is a posterior view. Anterior view looks like this. We can now see the lesser tubercle that we can't see from a posterior view. And we have two other fossae. We have the coronoid fossa and the radial fossa. Those are those flat areas now on the anterior of the bone. We also, I didn't have this in red, but I just want to mention the capitulum, kind of round area that articulates with the radius kind of loosely. Remember that proximal radioulnar joint is mostly between the radius and ulna, but the radius does articulate there. So that's just some review. We covered that last week. Any questions about humerus? Okay, and now you have that Google slide too. You got that diagram. Bless you. We can use that as you study. We've still got some time. I'm going to go back. I want to start talking about the pelvic girdle. We won't get too much into this today, but at least want to start mentioning it. The pelvic girdle is the kind of anatomical analog of the pectoral girdle, in that it's the attachment point for the limbs, in this case, the lower limbs. It's composed of 3 bones. So the 2 hip bones or coxal bones and your sacrum. Now your coccyx is also kind of in the middle here. It's not really part of this girdle. It's just a little bit that sticks off there, but you should know where it is and that it's articulation with it. We have the sacrum and we have your 2 coxal bones left and right. It's really important in a number of functions. One is it attaches your entire body to your lower limb. So basically all of the weight of your upper body is transmitted through the pelvic girdle down to your legs. It also provides support for your visceral organs. So your hips are kind of flared out because all of your kind of guts are in this abdomen region, your intestines, et cetera, et cetera. So it provides structure for that. The joints of the pelvic girdle are not very movable, if at all, and they're attached via these by these very, very strong ligaments. In the case of the sacroiliac joint, and by fiber cartilage in the case of the pubic arch. But these joints are not flexible at all. They're tiny bit flexible, but they don't allow much movement as all. The pelvic girdle is this really kind of solid, strong structure in the body. There's a couple terms on here that I want to draw your attention to. One is the sacroiliac joint. So the ilium is this part of your coxal bone. I'll talk about that in a second. And where the ilium articulates with the sacrum, you have the sacroiliac joint. Sense? We also have this cool structure called the acetabulum. This is the kind of cup that holds the femur in place as it articulates with the coxal bone. And the acetabulum is analogous to your glenoid cavity in the scapula, except it has a much deeper structure because it's much more, it provides much more stability simply because there's so much more weight being transmitted through that joint. So it doesn't provide as much freedom as movement. In other words, you can't move your leg as well as you can move your arm, right? At the shoulder joint versus the hip joint, but it's much, much more stable than your shoulder joint because it bears so much weight every time you stand or take a step. Yep, I've got Sophie and then Veronica. Go ahead.
It's like they work on their muscle.
Yeah, I mean, those kinds of movements are a whole bunch of joints moving at once. You've got all of the joints in, kind of your spine is involved with that, as well as the articulation between your femur and your hips, and also in your legs and your knees. So like kind of everything kind of moving together. So I would say it's probably just a matter, I mean, that's a good example of a matter of like training and practice allows you to make certain movements like that, but they're not necessarily like, there's nothing like special about the structures themselves. It's more about the coordination of the motion than the actual like range of motion. That's interesting. That question has never come up in class before. Go ahead, Veronica.
Or is there like a bit of separation?
There is a bit of separation, and there's basically some really, really strong ligaments that bind them together. So they are in fact separate bones. They're not fused, but they're super closely bound together. Very similar actually to the bones of your skull. We'll talk about that coming up, but they are separate bones, but they're super closely fused together. Jada, go.
This is kind of off topic, but on topic. So last time I was just strolling through in the TED Talk, and there was a woman who popped up, and she had 2 pelvic girdles. She was born like over 100+ years ago. So I don't know if it's true, but like, how could you have 2 pelvises and that be like? And apparently she had like 4 legs because she had 2 pelvises. It's like split her like axis or something. So like, how can you literally have 2 pelvic girdles, like pelvises? How does that work? I remember, like, I looked her up and everything. Her name was Myrtle Corbin. But, like, she was born with 2 pelvises. I was like, I don't know how. I saved this question for this class. But she had 2 pelvises. And she has pictures and everything. And she had 4 legs, had, like, 5 children. Yeah, her.
Huh. I'll be damned.
That one I don't think was a real picture.
That doesn't, no,
Yeah.
that's, yeah, but this is her Wikipedia page.
She had 2 pelvises and like 5 children. So like, how does that work?
Search me. I have never heard of this.
Like I'm searching so many different things about her because I was like, she had 4 legs. Yeah.
At the Pygus.
I was like,
Dang, Jada. All right. You know as much as I do. I didn't even know that would be possible. But there's cases like that, this kind of extreme congenital abnormality. Yeah, that's the part that's really shocking. I can't anatomically. Yeah, I don't know. So you go ahead. Mhm. Yep.
Is it possible that people
I have a slide. We're actually talking about that on Monday. Here's a slide that shows it's called pubic symphysis diastasis. So yeah, it can actually happen. So you get, that's what a normal pelvis looks like, and it can actually, this is a little bit dramatic, but it can actually be huge. And I'll talk about exactly that on Monday. Yes, yeah. Great, and we'll end our Friday with that. Exciting, yeah, and I'll get to that on Monday, so I have the slides. Right, just a quick reminder, quiz number 2 is now open. It's worth 30 course points. All the details are in your class program, so I'm not going to review them here. Just a reminder, though, it is due before class on Monday, so it's over the weekend. You have 3 hours in Blackboard to do it, although it's designed to take 20, 30 minutes. So in other words, take your time. Just as a quick reminder, remember that once you start it, you can't stop it and come back later. So once you start it, you have to finish it within that 3-hour window. So make sure you give yourself some time. Otherwise, I have a ticket out in your Friday Venn diagram. Let me know what questions you have for me. And yeah, this one's good, right? I was wondering if I should show this one in class or not, but it's pretty funny. All right, have a great weekend.